بسم الله الرحمن الرحيم. أبنائي الأعزاء، صباحكم ورد. محاضرتنا اليوم في مادة الأنف والأذن والحنجرة عن الدكتور عادل الميالي، أستاذ مادة الأنف والأذن والحنجرة في الكلية، حول موضوع من المواضيع المهمة اللي ممكن أن نشوفها كثيرا أثناء ممارستنا لاختصاص الأنف والأذن والحنجرة، وهو موضوع allergic rhinitis. كل شيء هواي تمر بينا، وجزء ممكن حتى في عادتنا نشوف ناس يعانون من هذه المشكلة frequent sneezing in different degrees whether mild or severe. المحاضرة راح تشمل مجموعة من المحاور. راح نبدأ بتعريف حول allergic rhinitis, then we'll go into the pathogenesis of or the mechanism of allergic rhinitis, then the clinical features of allergic rhinitis, diagnosis and treatment of allergic rhinitis. So what is allergic rhinitis and what is allergy in general? Allergy is an immunologic reaction, and it represents a localized defense mechanism against the invasion of certain parts of the body, and in our condition here is the nasal mucous membrane, by certain antigens that we call them the allergens. And upon this invasion, the body will react to the immune system will react by producing antibodies, and the type of antibody that mediate the allergic reaction or the allergy is the IgE. So probably you remember that we have what is called the hypersensitivity reactions, and we have 4 or 6 types of hypersensitivity reaction. The simplest type is type 1, antigen antibody reaction. So allergic rhinitis is type 1 hypersensitivity reaction of the nasal mucosa to certain foreign substances, which call them the allergens, and therefore the disease is an IgE mediated disease. So again, the disease is a localized defense mechanism of the nasal mucous membrane against the invading foreign antigens, which are harmless substances, we call them the allergens. ممكن تقروها أن يكتبوها allergens to refer to the route of entry of the allergens into the body by airborne route of entry. It is the most common form of rhinitis after viral rhinitis. It affects about 10 to 30% of adult patients. So the allergens are nothing but highly soluble proteins or glycoproteins. The roots of entry, the commonest route is in the inhalation, and at that time, or in this case, they are called aeroallergens, and the commonest example is the pollens اللي هو الطلع مال الأشجار اللي يصير في بداية الربيع، هذا اللي يتناثر اللي هو يسموه اللقاح مال الأشجار. The ingestants or the ingestion, وهذا هنا food allergy, and this is common in children, and the allergy to certain drugs like penicillin and salicylates. Again, this will give you some summary about the routes of entry for the allergens. Invasion through the skin, inhalation, exposure happens when the patient breathes in allergens or breathes in allergens through the respiratory tract, like cat hair, dander, peanuts, pollens. Allergens can also attack by ingestion to the GIT, for example, the milk or the chocolate. Now, let us have an idea about the pathogenesis of allergy. How is the allergy developed? For allergy to develop, there should be an atopic individual, some genetic tendency to develop an allergic reaction. And this genetic tendency will ensure the production of these IgE antibodies. and the production of the IgE antibodies will be stimulated by the invasion of the nasal mucosa by the allergens. And these allergens will stimulate the T, B, and the plasma cells cascade, what is called. So the first to be stimulated here, B lymphocytes, but when the B lymphocytes are found in the tissue, they are called the plasma cells. They've been differentiated into antibody-producing cells, which are the plasma cells. And they have the power to produce antibodies. These antibodies will fix to certain surface receptors on the surface of the mast cells, and upon fixation into the mast cell, the process is called sensitization, and the individual is being sensitized بهذا يتحسس من مجموعة من هذه الانتيجينز. On subsequent exposure or repeated exposure or next exposure to the allergens, the antigens will interact with the IgE-bound mast cells in the tissues and basophils in the blood. This results in the release of the inflammatory mediators from the mast cells like histamine, which is the most important and the most common mediator, allergy mediator, the leukotrienes, serotonin, prostaglandins, and steroid-acting substance of anaphylaxis. So the pathology of allergic rhinitis will depend on the release of these mediators. But what happens when the mediators are released? There's increased capillary permeability, and this leads to edema and the swelling of the mucous membrane. There is eosinophil infiltration, the common cellular infiltration into the area affected by the antigen invasion. And number 3, the alveolar glands, which are found in the nasal mucosa, will become stimulated, causing the release of excessive watery secretion. This may summarize to you the process of sensitization. Here we have some pollens من هذا الورد. Some pollens will come to the nose, so the nasal mucosa will become invaded by these antigens, and this will cause the stimulation of the plasma cells, and the plasma cells will produce these antibodies, which are IgE antibodies, and these antibodies will come to fix into these surface receptor sites on the mast cells. You see these granules in the mast cells, these granules are filled with allergy mediators like histamine, leukotriene, serotonin, and other mediators. On subsequent exposure, now the IgE antibody will become persistently fixed into the surface of the mast cells. And when the antigen is coming next time, it will attach into this IgE antibody on the surface of the mast cell, and this will cause the release of these mediators from the mast cells, like histamine being released. And the process of allergy will become initiated. Again, the allergen, like the pollen, will come through a respiratory route, nasal route, or inhalation, and the plasma cells will produce the antibodies, and these antibodies will fix into the surface of mast cells, and the next time the allergen, like the pollens, will come to interact with these IgE-bound mast cells antibodies. Now, the classification of the allergy is the allergy has got 2 sets of presentation, either acute or chronic. Acute, it comes in bouts and during certain seasons of the year. That is why they are intermittent. They may become calmed down, then it will become increased during certain time of the year. And their presentation is usually acute. That's why the symptoms are irritative symptoms there, like sneezing, like nasal discharge, and so forth. The commonest example is the pollinosis or the hay fever. And the word hay means like spring. The chronic presentation or the persistent disease, or also called the perennial allergic rhinitis, is usually presented with obstructive symptoms like nasal obstruction, like sleep disorders. And the main allergens here are the house dust mites, and animal denders. These are different examples of allergen. These are the pollens. This is the house dust. house dust غبار يعني مال البيت، هذا نشوفه في بزوايا البيت. هاي صورته بالضبط، يمكن لو تنتبهوا له حتعرفوه. وكل house dust mite هي نوع من الحشرات اللي تعيش بهذا الهاوس dust. And they are very provoking allergic rhinitis factor. What are the symptoms of allergic rhinitis? احنا عرفنا شنو هو definition of allergic rhinitis. خدنا فكرة عن pathogenesis and development of allergic rhinitis. Now, what are the symptoms? Nasal discharge, which is usually profuse and watery. Sometimes it may become liquid. Nasal obstruction, definitely from the swollen mucosa, from the presence of the secretion. It's usually bilateral. It could be intermittent and alternate, or it could be persistent. It depends. Sneezing and itching. And finally, olfactory disorders like anosmia and hyposmia. Well, the allergic rhinitis may affect the eye, and the eye may become red and itchy and watery eye. It may affect the throat, which is the pharynx, and it becomes itchy and sore, and some postnasal drip and cough. Chronic cough may indicate chronic allergic rhinitis. Signs of allergic rhinitis. The nasal mucosa is moist, pale, and swollen. The inferior turbinate is usually pale and hypertrophied. The nasal secretion is usually watery. Sometimes it may become mucoid, and polyps could be seen. And these are the signs of allergic rhinitis. You see, the mucosa is pale, it's been swollen, and there is some watery secretion here. If we send the patient for CT scan, we'll see that there is an allergic hyperplasia of the nose and paranasal sinus mucosa. All these structures are filled with hyperplastic or hypertrophied mucosa. Sometimes this mucosa may herniate from the sinuses into the nose. This herniated sinus mucosa is called polyp. بنسميها الزواد اللحمية. They are nothing but a hypertrophied nasal mucosa that herniate through their ostia, the ostia of the natural ostia of the sinuses, and they will become seen as polyps. Let's talk about diagnosis of allergic rhinitis. Allergic rhinitis is a clinical diagnosis. It is based on history, which is the cornerstone of diagnosis, clinical manifestations, and some allergy testing investigations. The history, which is the cornerstone of diagnosis: nasal discharge, nasal obstruction, these are the common symptoms: itching, sneezing, anosmia. And there is a principle saying that if 2 or more symptoms of these symptoms is persisting more than 1 hour on most of the days, then the patient is most likely having allergic rhinitis. The signs سبق أن قلناها: the nasal mucosa is swollen, it is pale, and it is moist. We may see some polyps, and if you send the patient for CT scan, you will see that the whole sinuses will become blocked with hyperplastic mucosa, and the mucosa may herniate into the nose through the natural ostia of the sinuses, and this herniated part of mucosa is called polyp. Now, what are the investigations that we need to do for patient with allergic rhinitis؟ شوفوا هسه هذا بده يدور، شوفوا وين راسه؟ بده يدور لأنه he wants to look for the diagnosis, to investigate the clinical problem. The first set of investigation is the skin tests or skin prick test. They are the commonest and the easiest test that is being used to investigate patients with suspected clinically allergic rhinitis. It's being used on the anterior aspect of the forearm. The positive test indicates that sensitization has occurred, individual is atopic. And atopic individual means that he has got the tendency to produce IgE antibodies. But this does not prove an allergic etiology for rhinitis. But it may raise the suspicion. هذا شلون نسوي السكن بريك تيست؟ نجيب الالرجينز ونسطرها على anterior aspect of forearm, and then we prick the skin and introduce these antigens into the subcutaneous tissue. The area will react like this, the skin will become red, shiny, and this swollen, some wheel and flare phenomena. Other allergy investigations were peripheral blood count, cell count, وأكثر شيء لفت انتباهنا هو increase eosinophil count in peripheral blood smear. But this is not diagnostic. Serologic tests to measure the total plasma level of IgE and the specific IgE, and again they have no diagnostic superiority. Nasal smears to see the eosinophils in the nasal smear indicate allergic rhinitis but is not diagnostic. هذا طبعا البريفرال بلاد سمير، نشوف هاي الايزونوفيل هاي من مجموعة الجرانيولار lymphocytes. See هنا شوفها كلش يعني كلش هواي منتشرة من عندها، عادة تكون كلش قليلة البريفرال بلاد سمير. Again, these are a picture of peripheral blood smear with rich of the increased number of eosinophil count. المعول عليه بالinvestigations هو provocation tests، واللي هو انه احنا بدنا نتحدى النيزل ميكوزا، نجيب الانتيجين and we put it in the nasal mucosa and we'll see the results. And definitely the result is that an allergic process will develop. اللي تشمل sneezing والitching والnasal discharge وغيرها. مشكلة هذا التست انه it is serious and it may يعني carry some risk to the patients because it may induce some anaphylactic reaction. How can we treat allergic rhinitis? There are three concepts in the treatment of allergic rhinitis. 1. Allergen avoidance. 2. Drug therapy. 3. Hyposensitization. طبعا الالرجين avoidance هو to avoid any known provoking factors اللي هي allergens. This is the most effective treatment modality or strategy, but is not always practicable. These measures are effective when the patient is allergic to single allergen and this single allergen is identified, is known. The common allergens in which avoidance is possible هي الhouse dust والhouse dust mite والanimal hair allergy by certain measures. مو يعني مو مستوى المرحلة اللي انت بيها، بس يعرفوا هذا الشكل. Okay. Drug therapy, and the aim of using the drug therapy is to modify or dumb down the allergic response. يعني إذا إما نسيطر عليه أو نحوله. And there are two concepts. Number one was suppression of the allergic response. Number two was prophylactic treatment. Suppression of allergic response, antihistamines is the mainstay of treatment. They act by the action of blocking the H1 receptors, and they are the mainstay in treatment of allergic rhinitis. الانتيهستامينز عندنا نوعين، first generation و second generation. first generation all the antihistamines بكلياتها كانوا يشكون من عندها انه sedating drugs. They may induce sleep, and they are sedating because they can cross the blood-brain barrier. They have an anticholinergic activity، وطبعا الاكشن مالتهم ما block the H1 receptors. مشكلة مهمة بها هي drug tolerance. With the time you need to increase the dose so that you will have the same effect of the treatment or of the drug when you use it for the first time. Second generation antihistamine ما بها أي شيء. They are non-sedating, no anticholinergic activity, and they don't cross the blood-brain barrier in the brain. The advantage of these drugs is single dose and no sedation. وطبعا no drug tolerance. Steroid therapy, systemic steroid therapy of acute, severe and intractable cases. Acute, severe and intractable cases. بس نخلي بالنا انه هذا systemic, and they may induce some serious side effects like the hypothalamo-pituitary adrenal axis suppression. intervention with the long bone growth. Therefore, or that is why they should be used for short periods. The topical steroids, they are the most effective medication in treatment of allergic rhinitis. They relieve the itching, sneezing, rhinorrhea, and nasal obstruction. Topical steroids, they have no systemic absorption, and therefore they have no systemic side effects. They are proved to be safe to be used in children. They may cause dryness of nasal mucosa and epistaxis. Topical anticholinergic, وأشهر واحد هو الإبراتروبيوم bromide in patient with excessive nasal discharge or excessive rhinorrhea. The prophylactic treatment هو إما نستخدمه topically or systematically. التوبيكال هو الصوديوم كروموغلايكيت، هذا فائدته إنه يسوي stabilization of the mast cells membranes to prevent the release of allergic mediators. الكيتوتيفين نفس الأكشن لكنه systemic and is being used for children. Leukotriene inhibitors, they deal with the late effect of allergy. Surgical treatment, whenever is possible, but its role is limited. To the relief of gross obstruction, septal surgery or turbinate size, drainage of the infected sinuses, removal of the polyps or other allergic points. In treatment of allergic rhinitis, surgery should be avoided in the nose and the throat of nasal polyps. شكرا جزيلا لإصغائكم. بالإمكان أنه تتواصلون معي أنا على الجوجل كلاس روم حول أي نقطة أو ملحوظة أو شيء ما فهمتوه من المحاضرة. أتمنى لكم الموفقية.